Okay. All right. Well, good afternoon, and thank you all. Well, everyone will probably be joining us. I would first just like to say we do apologize that we are a little bit behind today, but it is Monday and it's technology and all kinds of things happen. So hopefully, if you watch this now or watch it later, you will give us a little bit of grace. I think we all deserve it. Every now and then. We are doing a little kind of about face this afternoon. We're changing up just a little bit. And so this is also, we are still definitely going to talk about race and racism and maternal care. Dr. Collier is not on with us right now, but she may join later. And so we thought that this would first be a good time for us to first just really introduce our team and to talk about a little bit of their passions, and then we'll get into the discussion around race and racism in maternal care. So I'll start with our interns, Tyranny and Jazz, either of you, and then Asia, you can introduce yourself and kind of go into the conversation around race and racism, or set the conversation up for us. You're on mute.
Well, isn't that something? Well, hello everyone. I am Tyranny Marshall, and as Dr. Bird says, I'm an intern with Six Dimensions, and I've been working with 6D since January. And I'm a recent graduate of Alcorn State University with my bachelor's in biology. And this coming fall, I have already been accepted to Jackson State University to receive my master's in public health. And a part of the reason that what drawn me to Six Dimensions is our voices as far as like the black community and things that we face, we're not really heard, especially black women. And with my work in public health, I want to make sure to highlight black voices and our experiences, and as far as medical situations that happen and we're disregarded. And I just want to use my passion for that to help public health expand.
Thank you, Tyranny. Jazz.
All right, hi everyone. I am Jasmine Martin. As Dr. Burst mentioned earlier, it is Monday and my computer is having some technical difficulties. So my camera is not on, so please give me grace. Hopefully, my voice will suffice. I am a senior at Jackson State University. I am majoring in computer engineering with a minor in biology. My plans is to hopefully attend medical school in 2023. I'm in the process of applying for it at the moment. I started working at Six Dimensions with the passion of wanting to kind of bridge the gap between African American women and them receiving adequate health care, and with the emphasis on bringing awareness to the maternal mortality crisis on the national span, but also in the South. If you're not aware of it, the rates of maternal mortality is unfortunately increasing for Black women here, and a lot of these factors, the reasoning are not kind of, I guess, reason based. It's just race. That's the huge factor of it. So being able to use my knowledge in regards to technology, creating software to help bridge those gaps and make sure that women who are living in low income areas and rural areas are able to receive adequate health care, as well as working in the clinical side. So being able to connect to patients, being able to reach out to adolescent African American women is my lifelong goal. So I'm enjoying my time here. I hope that I can bring something to this team as much as they give me. So yeah, thank you.
Thank you, Jazz. Asia.
Good afternoon, everyone. And yes, our apologies for being a little delayed in our start time, but thank you for spending your Monday afternoon with us. We truly appreciate it. Again, my name is Asia Russ. I serve as a project director with Magnolia Medical Foundation as well as Six Dimensions. We are great partners in this public health world. You guys have saw me on the live before, and I'm just happy and just being honored to work in this public health realm, especially maternal and child health, because we are one of the world's most vulnerable populations. And I'm glad that we are advocating for ourselves and getting the message out there to the population that needs it the most. And just to give a little background on Black mortality, Black women are 3 to 4 times more likely to die from birth related complications than white women. And Mississippi's 2009 Maternal Mortality Review Committee report shows that Black women in Mississippi are 3 to 4 times more likely to die from birth related complications than white women. And the current systems uh, of care have operated have not operated equitably and have made one of the most fragile and most precious times in a woman's life to be scary and to be life threatening. And we want to continue to name racism as the root cause. So that's why we're having this discussion today. So thank you guys so much for joining us. We're gonna jump into a few I'm sorry, we're going to jump into the topic of what the Maternal Mortality Committee is and what they do. So, Dr. Burks, if you could just give us a brief overview.
Okay. Thank you all. Thank you, Asia. Thank you, Tyranny and Jazz. As you all can see, again, we just got a bad case of the Mondays, but it's okay. We are all working through it, and that's it. And when we get off today, we all gonna relax. But so speaking about the Mississippi Maternal Mortality Review Committee, and a part of the work that we do with these Facebook Lives every month is to highlight those the review committees findings. And so our last report for Mississippi was in 2019, and a new report will definitely be coming out soon. We don't have a release date for the new report, but Mississippi is one of, I think, almost 42 maternal mortality review committees across the country. So CDC has maternal mortality review committees that look at all the maternal deaths across the country and discuss why the deaths happen and offer recommendations for those deaths. Recommendations for community, policymakers, clinical staff, make those recommendations so that we can improve maternal health outcomes. And so I'm proud to serve as a part of Mississippi's Maternal Mortality Review Committee. But also, I think it's important to note that the committee also really looks at race and racism and how it plays a role in maternal deaths as well. And I know our statistics are bad, but one really promising and good thing is Mississippi is really leading the way with our maternal mortality review committee led by Dr. Collier, who is now joining us. But one of the great things about our committee is that Dr. Collier has brought on Miss LaJune Johnson, who spoke on one of our other sessions, who does family interviews. She's a trained social worker and really just adds kind of the context to the data that we look at when we look at the reports. And so our review committee is making waves across the country because if I'm not mistaken, we're one of the first ones to use that type of model. So I think it's really good, and hope that our committee can continue to do great work. So what I'm going to do now is I'm going to step back and step out. I'll stay here and hang around and monitor the chat. But Dr. Collier, everyone, I'm going to let y'all take the show today.
Okay.
Yes, Dr. Carter, thank you so much for joining us at this time. If you would like to give a brief introduction of yourself, your background, and what you do, that'll be great.
Great. Hey, everybody. Sorry for joining a little late. I'm traveling, but my name is Dr. Charlene Collier. I am a general OBGYN with training in public health. I've held a position with the University of Mississippi Medical Center and the Mississippi State Department of Health for the last 10 years or so. And in that role, I have been the director of the Mississippi Perinatal Quality Collaborative, as well as the Maternal Mortality Review Committee. So As Dr. Burst had explained, the Maternal Mortality Review Committee is established within our state to review all maternal deaths within a year after the end of a pregnancy. And we are particularly looking at those that are pregnancy related. We try to evaluate all maternal deaths to some capacity, regardless of the cause, and then try to look particularly at those that may have been actually caused by the person being pregnant. So we ask the question, would this person have died if they were not pregnant? And then we try to look at what are the contributing factors to that death and what can be prevented. So we don't just look at it around why did it happen, just to document it, but to really try to drill down to what were the causes and how can we prevent it, not just at that medical level, but every level from levels of policy to environment to the society and the community that person lived in, their upbringing, what they were exposed to, and yes, in fact, the experience of racism and how that can contribute to maternal deaths. So it tries to be a very comprehensive review. And as Dr. Burst also mentioned, we use multiple sources of information to review those deaths, and that includes family interviews is a really important part of it. So it's a little bit about who I am and what I do.
Thank you, Dr. Collier. You brought up something. I'm just going to go ahead and jump into this question. And when you guys are trying to determine if racism played a role in maternal death, what is the committee looking for?
Yeah, it's at multiple levels because we understand racism to not just be, and many people hear that and they think it has to do with one person not liking or being mean to another person because of their race. So you're thinking the Ku Klux Klan and hate crimes and just somebody like in their mind thinking really harsh negative thoughts that they're a racist and maybe they're proud of that and they are out there thinking like, yeah, I have these bad thoughts. And that is just one type, and actually more of an extreme type of racism that in many ways, thankfully, is less common than it used to be. That certainly used to be the standard and norm that people were very forward with those beliefs and actions. But that is less common now to have that extreme form of racism. It goes all the way to interpersonal levels that we often call implicit bias. So where did that bias against Black people come from? That comes from racism. So that isn't, we like to call it that because it seems a little less harsh, but we're not just biased at random. We're biased based upon the ideas that were once perpetuated or held of what is good, what is bad, what is positive and negative, and that anti-Black racism creates these biases that we have. So there's biases at multiple levels that aren't just about race. That's where we think about discrimination. That could be against body weight. It can be against skin color. It can be against poverty level. So we look at discrimination as a whole, and then particularly racism as one form. Racism also, we know, has a structural component where this does not have to do with individual actions. This has to do with the results of racist policies or policies that were once determined based upon this concept of a hierarchy of humans, like one group being better, one group being less, and policies and laws and entire communities being designed around that. So when you have a population, let's say, for example, a neighborhood designed based on segregation, and one neighborhood gets healthier food, gets access to green trees and safety and parks, and another neighborhood that's maybe a Black community not having access to those things, being closer to environmental toxins, not having access to food and healthy food. So you call those food deserts. Those aren't made by accident. Those did have racial and racist practices that underline them when they were created. We think of the practice of redlining, where the value of someone's home was literally determined by whether they were Black or white, and people did not have access to certain neighborhoods based on their color. So we all know those racist policies existed, and they still have impacts to this day because they have not been corrected. So anything, if people are very comfortable with the idea like, yeah, slavery existed and that was very racist, and segregation existed and that was very racist, we have to ask ourselves what has undone the harm from those things. And those things may have stopped. It may not be legal to do those outwardly racist policies and practices, but we haven't gone as far to correct them. And that's where the idea of, equity comes in, of trying to really correct those harms and undo those harms. So we look at racism from a very broad perspective, not just interpersonal. Um, so we're looking at, were there signs that this person's experience was likely not the same as someone of a different race, and that race was a factor in this person possibly not being treated the same, not being listened to, or was this person exposed to policies or practices because of their race, because of the environment and the community that they lived in. So yeah, we look at it from a broad perspective. There are states that are testing, and the Maternal Mortality Review committee at the national level that's really run by the CDC. There's not one national MMRC, but the CDC gives guidance to all state MMRCs, and they've given states guidance over what to look for in a patient's experience that may be a sign, because it's never going to be as clear as in the medical record. The doctor's never going to write, well, I didn't treat this patient the same because she's Black. You're not going to get that. And patients may actually have positive experiences where their family will say, the doctor was very nice to us, but we as professionals know the care was not up to par, and that there's no good explanation for why that person did not receive the standard of care, that it wasn't a knowledge deficit. It wasn't it was this, why wasn't this person listened to? The person presents with a concern and they just don't get the care they're supposed to get. So we call it like this gap. There's this diagnostic gaps, these treatment gaps that you just can't explain. It's unexplained variation in care where we know this is the right thing to do and it just doesn't happen. That's a trigger or a warning that maybe, there was differences in treatment, that racism may have been at play, that had that person not been Black, if they were white, if they were of the same race as of the provider. It is also important to know that that doesn't solve the problem. We know that having same race as your provider can reduce that, but that biased treatment can happen regardless. So we have to, even look at differences in care, because that's a consequence of, that's one of those consequences of having, that anti-Black racism being part of culture for so long, that there's that internalized racism, that someone may see someone looks just like them and they don't treat them as good as they treat someone who looks different than them. So it's a complicated process. It gets some tension in there, where people disagree. They're like, well, hey, you don't have any proof. But, my point about it is just because you can't see it doesn't mean it's not there. And more importantly, how do we protect people from it? That is more of the goal than proving that it's there or not. Whether it's, if we prove it's there, more importantly is, was there anything that could have protected this mother from biased care? And that's another way of looking at it. And if that hospital has not, or that, and that hospital hasn't put in any training, if that hospital doesn't monitor their outcomes by race and can tell when things are different, if that hospital doesn't have a system that allows patients to be heard if their initial complaints are not addressed, then there's no protection in place against biased or differential care. So we look at it in a number of ways, and we're trying to come up with solutions, but it can be challenging.
We have a couple questions in the chat. Raquel, I'm sorry if I said your name wrong. She says, I'm so glad this work and research is being done. When these underlying discriminations and racism are determined, what are a few ways that can change the outcome? And what are the disciplines or interventions?
Yeah, coming up with the solutions is challenging because, as I presented, are we trying to change people's minds? Are you trying to protect against the harm that can be caused from it? And changing people's hearts and minds and the training, that's what all that training is about. That's kind of doing the implicit bias training. Everybody acknowledging that they have their own biases, which everybody does. I have my own biases. And if, I have to think about them and say, okay, If I can think about them, then I can check them, ask myself, hey, am I not listening to this patient because of this or that? Everyone has to do that practice in medicine. We have to start acknowledging that you have biases, and you have to acknowledge them and check them at the door and see where you are sensitive to that. And people have to acknowledge it. So anyone who resists it and says, oh, I don't see color, I treat everybody the same, it's just not true. I mean, if a patient walks in the room and they're from my hometown, they went to my alma mater, they look like me, and they know my mama, I'm probably going to be nicer to them. I'm going to smile, I'm going to chat with them, we're going to laugh. They're going to get 30 minutes of my time. Whereas that next patient walks in, and I look at them and I see, and I know this happened to me personally. I moved from the Northeast to Mississippi. I was worried every white person was a racist. I was worried because that was what we get told in New Jersey. You're moving to Mississippi, there's going to be crosses burning on your lawn and the Klan in front of your house. Like, that's what you get told. And so I had a bias against, especially rural, low income white people, who I would walk in that room and I would automatically assume that they were racist or that they didn't want me as their provider. That was my bias that I had to get over. So do you think I walk in that room smiling like I do the patients I relate to, or making conversation the same way? No, I'm not treating them the same. I may be uncomfortable. My body language may be off. So how does that patient feel when I'm acting like that and they have a concern and they're like, I'm not talking to this person? But that happens every day, and we have to check those behaviors. But there are people out there that resist that. They want to say they treat everyone the same, and that doesn't get us anywhere. So there's personal work of like, acknowledge your own biases, understand how racism is at work. And then I think specifically anti-Black racism, it's not enough to say we're all biased, because all the bias doesn't harm people the same way. We don't see my bias isn't causing, disproportionate deaths among rural white women, or we don't see these disproportionate deaths affecting everyone. We see disproportionate deaths particularly affecting Black mothers and birthing people, Indigenous mothers and birthing people. So there is a disproportionate harm being caused by particularly anti-Black racism. So everyone has to really think particularly about how Black people giving birth and their families experience racism. The other part is about just knowledge and advocacy. I think having a provider where you feel you're going to be listened to, you're going to feel like you're going to be heard, you feel like if you don't have that connection, if you feel like you're not being acknowledged, and you're pregnant, you're not bound to that one person. And if you are, because of where you live and it's hard to find another doctor or another medical provider, having an advocate is a big deal. We went through COVID where people were alone during birth, during pregnancy and prenatal care. And I truly believe that was a significant contributor to the increased maternal deaths, because you didn't have that person watching out for what was going on. And this is just general patient care and safety. It's not even about just racist care, but particularly for Black mothers who we know in medicine are less likely to be listened to, whose pain is less likely to be acknowledged, who, in Black people generally, if this is a standard of care, they're less likely to get recommended the standards of care across multiple areas of medicine. Even medicine itself being designed with racist practices. We know, like the pulse oximeter and oxygen not picking up on darker skin tones, or the VBAC calculator calculating against Black race. So there's a number of things like in medicine that were inherently racist. And having an advocate, having knowledge about, what is the right level of care is a protective factor. But so having, if it's not family, doulas. Of course, I love doulas. That's why I think they're such a major solution, because they're just they're there to be there and support and advocate on behalf of that birthing person. And it makes it a lot more difficult when someone's not getting heard or not getting that standard of care. So there's a lot of levels of addressing it. I think I try to look at it as these long-term solutions, which is like changing society. That takes a lot more work, and we have a lot more resistance to that. Even as like places like Mississippi, they're banning the education of talking about racism or talking about these topics, even equity. If that's getting banned, we are further away from changing the culture, the hearts and minds, and these conversations have to keep happening. So that's the long solution. I also worry about what's going to save a mother tomorrow. I can't wait to change the heart and mind of each individual medical provider, nurse, front desk staff, phone person. Hospitals have to put into place policies and practices that protect people from variations in care. There should be a standard, and the standard has to be met, and there has to be accountability for that standard. And that's what keeps people safe. It's regardless of your color. It's like, if you're bleeding, you get this. If you have high blood pressure, you get this. And if you don't, there's going to be some kind of escalation or consequence or reaction within the system to prevent that from continuing. So we all know the case of Serena Williams, and she's saying, I'm concerned, I have, I'm not breathing, I feel like I have a PE. That level of concern should be met with a certain action, period. It shouldn't be like, variation where one patient you do this, another patient do that. There should be standards around, okay, concern for PE gets this kind of workup. Shortness of breath gets this kind of workup regardless. So we need both solutions happening at the same time, but they look very different, kind of that long diversity, equity, inclusion, read books, talk, try to come to some social, justice, we all get along, but we can't wait for that either, right? You can't wait for that. It's been a long time to undo the harms of racism. And yes, we're better as a society, but some ways we're not, so we don't have time, we don't want lives on the line, depending if, that particular person you're interacting with on that day you're giving birth happens to have completed their DEI training. That's too much on the line to put into someone's hands of whether or not they absorb the training. We need, systems to protect people from variations in care.
We have a couple questions in the chat. I think you've hit on a couple of those topics. It says, how can we protect mother and child? I think you covered a lot of that. One of our questions from Latoya Sanders says, if racism is found to be the cause and the hospital has no protections in place, what happens?
Yeah, the MMRC isn't like a punitive committee. It doesn't have the ability to go in and, it's anonymous. So the committee is really looking at the circumstances to make recommendations. So the ability to have those levels of consequences really falls within a hospital. So these are not medical reviews within a hospital system. Hospitals do their own reviews usually of severe events or maternal deaths, and they can build out like what's our internal response. But we create the recommendations. Sometimes we have contact at hospitals and let them know like these certain changes should be made or these kind of things need to be considered. But it is usually not just the only thing. It's usually, it is the starting thing to say, okay, this mom needed high blood pressure treatment. We think she didn't get it because there was bias or racism at play. So in the end of the day, she needs a high blood pressure treatment. That's what would have saved her, not like your doctor needs a DEI training. In the end of the day, she still needed the high blood pressure treatment. So it still may be, there's still multiple things going on that are both medical and social and policy level. It's not usually just one solution when we think that there is discrimination or racism, but it is tied to the answer about why didn't this person get this care. And even if folks don't want to acknowledge that racism had anything to do with it, we still have to come up with like what would protect that mother moving forward or that person moving forward. So and the reason I think the whole topic, it's called racism and not race. And that is one of my mentors and heroes, Dr. Joya Perry, she is always saying that. And it's such a truth because in medicine, we see race listed as a risk factor across literally everything. And it's usually Black race. And there's zero explanation given. It's like, what are the risk factors? Black race. There's never a why. And that's what this is about. This is about saying you are not allowed in 2022 to just say Black race without a why behind it. So if you've done some genetic testing and research and you've proven that you've identified a single gene within Black people that causes this higher burden of death, please present that, because no one's ever found it, because there is no single gene, there is no single genetic characteristic that all Black people share. Yes, there's common ancestry, but it is a social construct, meaning we decide what it means to be Black, we decide, who fits in that group, and is not tied to a single biological or medical, fact that's shared between people in that population. So when people have all through medicine listed race as a risk factor and saying, okay, Black women are 3 to 4 times more likely to die. If you stop there, someone in their mind can make up the rest of that sentence. They can say they're more likely to die because something's wrong with them. Obviously, they die more, something must be wrong with them. The next person hears that sentence and says 3 to 4 times more likely to die because of racism. Those two people never have to communicate. One can go about their day thinking it's because something's wrong with Black people, and there's nothing you can do about it. It's biological. They're at high risk just because we just recently heard that Louisiana lawmaker saying there's some reason why they happen to have a higher rate of death. So it's the not acknowledging all of the reasons from the beginning of Black birthing people's experience in this country being grounded in chattel slavery, and from that point the entire system being built off of that is going to create bad outcomes. It wasn't designed to create great outcomes. So the not explaining the why is why we have this topic today, calling it's racism and not race, because people need to start questioning whenever something's presented as a disparity. I think we've been very comfortable with talking about disparities in health and public health. Say, hey, there's a disparity, but not the why. Because once you start digging into the why, then you start identifying how differences in treatment, particularly differences in policy. People are just individuals. You really have to look at how policy has driven differences, and that's where you can make a single change that affects an entire population and generation. Because when you impact one person, you impact one person and the people they interact with. But you really have to look at, if you're looking for generational change, look at those policies. So that's why we have that statement there, just so that it's clear that you have to dig deeper. And when you do, you see, why racism has been underpinning so many of these disparities we've been talking about, but not confronting that harder conversation. That was a long answer.
No, I was going to say thank you, Dr. Carr. You have given out so much important information, even in just answering your questions. We're going to ask you one last question just to wrap up everything. And if you guys have any more questions in the chat, this is the time to do so now. But for those who want to learn more, get involved, and work to address systematic and structural racism, there are some resources that will help people better understand the role of racism in the Black maternal health outcomes. Can you give us some books to read, or authors or activists to follow that can help us help ourselves?
Yeah. All the books are out there. They've been written. I think that's another important thing. Like if your job is like getting together and saying, what can we do, or where do we learn? Like, it's been written. No one needs to recreate anything.
Create the wheel, right?
Recreate the wheel. The studies have been done. The books have been written. I would say Dorothy Roberts is an excellent author and scholar. Killing the Black Body, Fatal Invention, talking about really race. I mean, and some people have to start there. They're not ready to confront even the concept of racism. You have to start with the concept of race. And people don't understand even how race has been defined, redefined, recreated in this country. Having some perspective on how race has been created allows people to see, okay, this was not a biological construction. This was not a genetic definition. This was something grounded in political structures and racism. Like, you have to start there. The National Birth Equity Collaborative, which is Dr. Joya Perry, as I mentioned, that's a great resource for training and education. There's so many within obstetrics and gynecology. Dr. Rachel Hardiman and the work they're doing in their lab. So much amazing research being done there. Monica McLemore is another a scholar around Black maternal mortality, a great friend of mine, Dr. Karen Scott, who came up with the PREM-OB scale, which is a patient-reported experience measure of obstetric racism. She validated and created the first measure of racism in obstetric practice. And it's actually a tool that can be applied by hospitals and practices. And even our committee, she's trained us. We've done some education with Dr. Scott about how do you actually determine if, measuring the experience of racism. So Donnaine Davis, Reproductive Injustice is an excellent book. I would recommend everybody read, particularly about that topic. Deidre Cooper Owens, which is Medical Bondage, going back to that history of racism and history of OBGYN and our whole field. If you're in the South, which we are, most people watching, you can go to Montgomery, Alabama, and visit the museum around Betsy, Lucy, and Anarcho, who we call the mothers of gynecology. And those are the enslaved Black women that the father of gynecology, Dr. J. Marion Sims, who operated and experimented on them to really create the field of OBGYN, but did so without anesthesia, without, really using their bodies. And that site in Montgomery, Alabama, Dr. Burst and I visited, and was an amazing experience just to acknowledge how Black women's bodies have been used and experimented, and has created this perception of our bodies being superhuman, can take more pain, can take more problems than other women. We could just endure more. So you read that and you get that understanding, and you start to see where some of these ideas come from, where somebody, doesn't have empathy or sympathy, that doesn't listen to a Black woman. They say, you're okay. Like, that's where those ideas come from. You can't enslave a person and while they're pregnant expect them to work and think of them as human or the same as, a white woman who must be protected and, not put into a field or working. So there's foundations to all this that you have to understand in history, and it helps you understand for today. All the books are out there. So I think people do have to educate, of course, themselves, but at the same time, I think preparing yourself, and, people ask, like, what do you do? What do you do to stay safe? What do you do to prevent it? I think, again, if you're able, you find a medical provider that listens to you. And you can tell that at the first visit, and that they have, like, what if you're not there? How do I know? Who do I go to after that? Having that doula, or, finding someone, a doctor, a midwife, just someone you feel like can listen to you. How to ask those questions to say, okay, well, what would you do? How would we know if it is something life-threatening? What would you do? How can we be sure it's not something that's life-threatening? What would you do for your mother? I asked that because in the end of the day, it's like, if people treated every patient like they did themselves or their mother or their sister, I can't imagine you would have this variation. So I ask that question. I tell patients that this is what I would do for myself or my mother, and that's a really high standard. I think we should apply to all patients, right? So, yeah.
One last question in the chat. Raquel says, can policy be biased? I can imagine racism influences some policies, which can be scary and frustrating.
Oh yeah, for sure. I mean, that's our whole. I mean, that's the foundation of all the laws that have had to be undone around segregation. And I mean, our healthcare system literally, used to have two systems. You didn't have one system for everybody. So policy can be. It even happens today with just how voting districts get drawn up, so that when you vote, you don't have as much power as somebody else, and that happens every day. So we still have to be very conscious about voting and the influence that has on health, and thinking about the consequences in health that policy decisions are made. And policy is a big word, and people are like, what does this mean? It's not just government, it's hospital, it's job practices. Like, if your job, if think about with Medicaid. Medicaid is a health policy in the end of the day. And we have chosen in Mississippi, our legislators did not opt to extend postpartum Medicaid to a year. We had that option to vote to cover pregnant and people until a year postpartum after they have a baby. And it did not get chosen, it did not get selected. So when I now review a maternal death at so their coverage ends at 60 days postpartum. So now if I get a mother who dies at 80 days postpartum because she's not on the right medication, what do I blame? What do I say killed her? Do I say not being on the medicine killed her? Or do I look and I say she's not on the medicine because it's not covered and it's too expensive and she's not on health insurance? And why is she not on health insurance? Because someone chose not to extend postpartum Medicaid. So that was a policy choice that resulted in a maternal death, if you really want to come down and be frank about it. And if people have in their mind the reason they're not willing to support Medicaid extension or expansion is because in their mind they think of it as something, welfare queens and black, they have this concept in their mind, which was true, in the 90s and the 80s, this concept of welfare queens and people just using the system, and if they perceive black people as being the ones consuming Medicaid and they don't see them as the voters that they care about, even though 65+% of births in Mississippi are covered by Medicaid, so that's plenty of white women in Medicaid or white people getting Medicaid. But if in their mind it's someone who looks different from them, and so they feel more comfortable not extending that practice because they think it's to someone that doesn't look like them, not their voter, then yes, that's a bias in a policy. So it seems like people are like, oh, well, this is medical and that's political, but it's still politics. If you can't get the care you need because of political choices, then healthcare is political, and so you can't kind of bury your head in the sand about it. We certainly know there's going to be a lot of consequences to policy choices as it relates to health. Be active, and I know, for example, the mothers that I take care of on Medicaid are working mothers. They're at the backbone of our community. They're working at UMC. They're working at the health department. They're at schools. They're running. They are the foundation of our community, and they deserve great health care, but so, we have to be thinking about that when we're looking at policies, is who it's really impacting. So I know we've probably gone over.
Oh no, we haven't. Dr. Burrs, is there anything you would like to add at this time?
No, I just wanted to thank you all for everything. Dr. Collier, I'm glad I didn't have to fill in for you today. Thank you so much for I know we know you're busy, and we understand how things work, and so we appreciate you for coming on and just providing context, because I think it's important that people do know and are aware of the Maternal Mortality Review Committee, especially I can remember those days when you were like looking in, newspaper articles for obituaries and things like that and trying to pull that data, but more people being aware of the committee and understanding what the committee does will help us continue to spread the results. And our results, that the report that came out in 2019 is still relevant as we wait for the new report to come out. And I would just encourage everyone to read the reports as you prepare for the next to come out. And I saw a lot of comments about like, what can we do just as individual people? And I always get a little disturbed by like the answer to that, because it's very complicated. I mean, we can advocate as much as we want, but the biggest part of that is things like policy, systemic and structural change that does not happen overnight. And it's a lot about this system that we live in. And so that's really important. And there were questions about these resources, and we'll compile all of these and make a social media post for everyone that was asking about the books and things like that. But I just appreciate you coming on and just taking the time to do what you do best, and just give us the facts. And, I think Raquel said it, we all go to the trainings. We are sometimes preaching to the choir. And so I think every opportunity that we have to spread this information to someone who may not, um, who may not listen, who may not be a part of the conversations and a part of this little choir, so to speak, that we're a part of. I think we have a responsibility to speak up during those times. And so if anyone watches this, if you watch it later, you can't go back. You know the information now, so you have a responsibility to share. And that was all I wanted to say, Asia. Thank you all. I'm gonna back out again, but if there are any other comments or questions, y'all take it away.
The only other thing I would say, thank you, Dr. Burrs, because you definitely spread it's a lot of work. It takes a lot of time to review those cases and get the recommendations out. So working on the report actively, but having these conversations is the best way to like share that learning. So I appreciate your Six Dimensions, just really giving legs to it, getting it out there, sharing it with people, and hopefully we'll get that new report out soon. But I think on the other side, that's really important that I don't want to lose sight of is like, I don't want people in pregnancy to lead with fear. I think that's like not the goal, is that we have to just be defending ourselves, because that's part of the stress that causes more Black women to have high blood pressure and to causes a lot of that problems. We look at that underlying stress, because sometimes racism causes stress and like life circumstances cause stress. And that's why we see higher preterm birth, higher hypertension. So it's just that hard lived experience of always having to worry. So I want not the goal to be like, how do we prep ourselves for war when we're pregnant? It's how do we like make pregnancy and birth a loving, kind, uplifting experience for Black women and birthing people. And I think we have to do that ourselves. Like, we're not have to wait for anybody to love on us. I think that's why like midwifery models of care and doula-led models of care, they're just different. I'm a physician. I get trained in a certain way. We don't talk about love and nurturing and kindness in anywhere really in medicine. It's just not part of the culture of medicine. Yes, when you need surgery, you want a surgeon. You're not looking to be like loved on. You need an operation like right away. But if pregnancy is not like that, it is both a medical and a social and a spiritual experience, that it really matters that the community you're in. And I think a lot of the work that's needed is recreating that community, just where when someone's pregnant, it's a celebration. They say it takes a village to raise a child, but that starts with that pregnant person feeling loved and supported. And so if that's like visiting a postpartum mother, bringing her some food, like think about those cultural practices that were once common in our culture, that has been lost in a lot of ways, like having that mother have visitors and bring her food and watch the other children and keep her out of work or keep her in the house. That was, we call it like my patients will come and say to me, hey, my grandma said I can't go outside. And I'll be like, yes, of course you can go outside. But that was really a protective thing, to leave that mother in the house. I mean, she's not running to the grocery store. She's not running errands. She's not running back to work. She could not go outside. She had to stay in the house and be spoiled and cared for. And we don't do that anymore. We say, because medically, we don't have like, oh, yeah, you can go out. There's nothing bad's going to happen to you. But maybe that is what's bad happening to people when they're rushing back to work 2 weeks postpartum. And then we have infant related deaths or maternal deaths because they're barely healed from their C-sections and they're back working at a cashier line. Like, this is us not taking care of each other in some ways. So we have to think, how can we create pregnancy to be a safe place? We don't have to wait for policy change for that. I think we just have to find opportunities. If it's your church, find ways to show kindness to pregnant or postpartum people, to mothers, these support groups. I love the organization Mommy, the MOM.me rocks. They do maternal mental health support. All moms have some kind of struggle. All families do. I don't care. It doesn't always have to reach a level of depression, anxiety, or postpartum depression. Everyone has some kind of struggle and everyone needs support. So I think we can find ways of recreating that experience, where we're uplifting, that we don't always have to be so worried about that protecting against harm, because we've got that village there, you've got that community there, people who you can call upon. So I think we can think around those solutions as well. And I think that's a lot more in our own hands, just, creating community and kindness, than necessarily those policy changes, which are a little harder. But yeah, I just want us to not always frame it in terms of death and destruction. Like, we need to think about Black birth as a beautiful thing and something we want to celebrate, and that most people do have healthy births. I think that's another thing in people's mind, is like all births are bad, and they're not, but we can try to replicate it and reduce the ones that are, result in bad outcomes. So that's and I guess the last thing I have to say is I didn't do my disclaimer. These are my opinions and not that of my employer. So I think that's important, just because it is a challenge when you are working at the state and for the university, and how people interpret these things. But as it's the truth to me. Like, it's not something I'm afraid to say, or it is the truth. And we've just come to a point in time where we don't want to sacrifice people's lives for just covering that up or keeping people comfortable. We got to get past that and look for, real solutions. So I thank all of you who joined. I wish I could see everybody here, but hi. Thanks for
Yes, everyone, thanks for joining in. Thank you so much, Dr. Collier. We really appreciate it. You have changed my perspectives on things. Just listen to you talk, and I truly appreciate it. I'm going to take some things that you said and charge it to my own life and personal life, and how my perspective is and how I look at things. So thank you so much, Dr. Collier. And if I feel like that, I'm pretty sure all of you who's watch it now or later will absolutely feel the same way. Again, thank you guys so much for joining. We appreciate it, and we will see you all on our next Facebook Live. Have a great Monday evening. Bye bye.
Bye.